Okay, hello everyone. Thank you all for attending this province-wide rounds. Today we are privileged to have Dr. Zaibo Li from the Ohio State University Wexner Medical Center to share their experiences on digital pathology and artificial intelligence. Dr. Li completed his residency fellowship in breast and gynae pathology and cytopathology at University of Pittsburgh Medical Center. And his practice and academic interests are breast and gynae pathology, cytopathology, and digital pathology. Dr. Li is currently the professor of pathology and endowed university professor on service professorship, and is the director of cytopathology and cytopathology fellowship program, and associate director of the digital and computational pathology at the Ohio State Wexner Medical Center. Dr. Li has published more than 150 scientific articles and many book chapters. He is currently served as a section associate editor or sitting on the editorial board for multiple pathology journals and served in multiple national society committees. He has presented lectures on many national and international pathology conferences and teaching courses. And today, Dr. Li is going to talk about their experiences on implementing digital pathology and artificial intelligence in their institution. And his talk comes actually in the right time because we are in the process of implementing the province-wide digital pathology system. Dr. Li, the floor is yours.
All right. Thank you so much, Dr. Go, for the invitation and a very nice introduction. You can hear me well, right? Just to make
Yes,
sure.
we can. Yes, we can.
Okay. It's my pleasure to present or share my experience, our experience at Ohio State with you. Let me go ahead, share my presentation. Can you see my
Yes, we can. Yes, we can.
Okay, yeah. All right. Again, thanks for the invitation. So today I'm going to share our experience in the implementing digital pathology and AI for clinical practice. Again, I'm from the Ohio State University in Columbus, capital of Ohio. Here is our medical center main campus with University Hospital, Heart Hospital, Cancer Hospital, and Spine Hospital here. And in 2026, we are going to have a new medical tower right next to the Cancer Hospital. I have the following conflict of interest, but none of this is related to today's talk. Here is my outlines, including implementation of digital pathology for primary diagnosis, step-by-step sign out digitally, and integration of AI into routine pathology practice. As we know, for pathology, especially anatomic pathology, it's more, related to the images. We look at those pictures, images through microscope. Digital pathology basically is to digitize those images into digital format. Then computational pathology will combine artificial intelligence and digital pathology to extract meaningful information from those digitized images to help you help our pathologists on diagnosis, such as tumor detection, IHC, and other test scoring, morphological subtyping, disease diagnosis, or prediction, including mutation status or therapy response, or prognosis, such as survival, clinical outcome, and others. I'm going to use this 5S plus 4I to explain a successful implementation in our institution. The 5S is from Dr. Hanna, Matthew Hanna from MSK I know he's moving to Pittsburgh this summer from his publication, including the followings, and also for I came up with these 4 I's, including image managing system integration into your pathology, LIS, lab information system, and image adoption by pathologists. The final category is the image analysis, basically AI. The first ad is sponsorship from leadership. I don't know, some of you may know Dr. Neil Parwani. Currently, he serves as a vice chair for anatomic pathology. When he moved to Ohio State from Pittsburgh, basically he received a support from the leadership to build this 10-year project with the digital pathology implementation, supported by our research fund, Pelotonia, which is a fundraising event in Ohio's, in Columbus, to support Ohio State cancer research. Second F stands for scanners or digital pathology system. As we know, it has been several decades for the digital pathology or scanning system development. Nowadays, you have multiple choices on the market, ranging from a very small single slice scanner to the high throughput scanner up to, I think, over 1,000 slides per load right now. Here, just a very small scanner. Now you can just buy a small scanner for yourself. This is the one on my desk. It's a Grandium. You can see, how small it is contrast to my microscope over there. So far, 3 digital scanning systems have received FDA approval in US, including Philips in 2017, Leica system in 2019, and the Hamamatsu system in 2022. Actually, our institution participated in the Hamamatsu clinical trial experiment. This is a publication from our department a couple years ago to summarize the current commercially available hardwares, scanners. I think some of them may be outdated, but it summarizes the multiple scanners from multiple vendors, including those specific parameters in this table. Currently, in our institution, we have the following scanning system or scanners. The main one is the Philips Ultra Fast. We have 9 of those, and these scanners are for our primary diagnosis. We also have a Huron scanner to scan whole mount slides, mostly for prostate resection specimen. We also have a Hamamatsu like April 82 for clinical trial research teaching. We also have some small so-called robotic microscope or hybrid robotic microscope scanner, including Sakura Vision Tech like April LV1, Microscan, or Gradient, basically for fluid section, rapid on-site evaluation, or remote secondary consultation from our outreach community hospitals. We place the third F stands for space. We place the majority of our Philips scanner in our histology lab, which is off campus. And the scanners stationed right next to the stainer. So whenever the slides come out of the stainer, they will be scanned immediately. On average, we scan up to 3,000 slides per day. We also have a second scanning center located in the campus to scan console cases and any urgent need. We have staff for both locations to scan slides, and also we have an image specialist to help to QA WSIs, IMS maintenance, and unexpected issues. Additionally, we have a pathology hub to track all digital images and glass slides. We also have a digital pathology core facility with other scanners for teaching, for research, for clinical trials. The fifth F is for storage. Currently, we have store all our digital images locally at the Ohio State with a 3 tiers storage. Tier 1 is Xbox to store metadata for all digital images. Tier 2 is the so-called hard storage using ESLint from Dell. You can retrieve the images from this storage very fast, but this storage is very costly, expensive. Tier 3 is a skeleton RAIN system. We use this for permanent storage. Whenever the slides are roughly 1 year old, we move those slides to this storage for permanent storage. The advantage is, the system is much cheaper compared to the tier 2 storage, but the images on this storage takes longer to retrieve. Also, for the storage and the network is important. As I mentioned, we store all our digital images in the IMS locally in OSU data center. Also, we have our anatomic pathology, LIS. We are using Epic, Speaker, also located at the OSU data center. Both servers connect to OSU network at 10 gigabytes per second. Then we have our scanners connected to OSU network at 1 gigabytes per second. For workstation, basically for the pathologist office or any workstation in the lab, we connect them to OSU network at 1 gigabytes per second as well. Finally, we also connect our pathologist home office to OSU network via VPN connection. The speed will be dependent on the home internet connection. Optimally, at least 300 megabytes per second for the internet connection. Before you can do primary diagnosis, you have to validate all your digital scanners and also, for the pathologists who are willing to do primary diagnosis using digital images. We follow the CP guideline. We validate all our scanners, each of all scanners using at least 60 cases per application. Additionally, we include 20 cases for IHC and special stents with a total 100 cases, usually 100 slides, 1 slide per case. The washout period is at least 2 weeks between looking at digital and glass slides. That's the CEP guideline, which is only for surgical pathology. Under the leadership of Dr. Liron Pantanowitz, last year, ASC, American Society of Cytology, we have a digital cytology task force. I was the chair for that task force. We came up with this digital cytology guideline for digital cytology clinical practice. It's similar to the surgical pathology guidelines. You need at least 60 cases from your cytology practice. The only difference is that, we all know surgical pathology pretty much, HE stent slides plus IHC and special stents. But for cytology, you have different preparations, including smears, including liquid-based cytology, cytospin, and cell block, with a different staining protocol, including such as a PEP stain or diff quick stain. So the number of the slides that should be included per validation study in this guideline is at individual lab's description. However, at least 1 slide per preparation stain combination is needed for the validation. Similarly to the CAP guideline, or concordance of at least 95% should be achieved between glass reading and digital reading, and a washout period at least 2 weeks is required. The first eye is an image managing system. There are many image managing systems on the market. Some of them have received the FDA approval as listed in this table, and some of them have not. Some of them are, relatively open system, but some of them are relatively closed. When we talk about open or closed system, mainly whether you can easily to add third-party applications into the image management system. We are using Philips image management system as shown here because at that time when we implement digital pathology in 2017, at that time only Philips received FDA approval. The second eye is the integration. You have to integrate the IMS into your pathology lab information system. As mentioned, we are using Epic Beaker. We transitioned from CoPath to Epic Beaker in July 2019. Right now, we have integrated the Philips IMS into the Epic Beaker. If you are using Epic Beaker, you are familiar with this window. On the left, you have your work list. Middle is your diagnostic area. On the right is the case information. Here we have two additional functions. After we integrate the image IMS into LIS, you see this launch image. You can launch the entire case, or you can just click a single link as shown here for specific slides. For example, you have already looked at HE, you only want to look at the immunostain as shown here. You just send it to click that specific link. That will bring you to the IMS. Then you have this digital images to look at. The third eye is the image adoption by pathologists. This has been a very slow process for us. As mentioned, we started the implementation in 2017, 2018. We started the primary diagnosis. This is Dr. Anil Pawani out of the first cases, prostate biopsy using digital pathology at our institution. However, by the end of 2019, only 7 pathologists out of 60 at our institution started to use digital pathology to do primary diagnosis, but not completely. However, the pandemic hit, COVID came in 2020. We actually saw a significant increase of adoption of our pathologists using digital pathology, especially using digital pathology from home. By the end of I think last year, we have about 80% of our pathologists are using digital pathology for primary diagnosis, either fully or hybrid format. All right, let's go to next part, how we do the primary diagnosis using digital images. I hope this is not your office. My office does not look like this even before digital pathology adoption. For glass slides, you can easily break it or lose it. You have to write down your annotation on the slides, glass slides, make lots of writing. If you have a digital pathology implementation, your decks may look like this without any glass or paperwork. Here is my desk. This is a standard setup. We have 3 monitors. The right one for image viewing, the middle one for LIS. We are using Epic Beaker, and the left one, I put it in vertical. You can, check emails or read papers. For computer, if you do not run AI locally on your computer, you don't need any special computer. Just a regular computer is fine. We do have a AI system with your firm installed locally. So at least some of the pathologists, we have the GPU powered desktop computer in our office. For monitors, there are choices. You can have FDA approved or non-FDA approved. So we are using a barcode monitor as shown here on the right with the Philips brand, but you can use a non-FDA approved monitor as well. Keyboard, just a very standard keyboard, nothing special. But for mouse, you have you should probably have your personal preference. After many months of trying, personally, I like this trackball monitor on the right. We do have a 3D mouse as well. This is a regular mouse. When I have a resident sitting down with me for sign out, I give this mouse to the resident, so we can both point to the area we have an interest. Additionally, you can have a very fancy mouse like this space mouse or a vertical ergonomic mouse, and it all depends on your personal preference. As mentioned, we are using a Philips image management system. When you open your case in this image management system, you will see the window like this. You have 2 tabs, lab and my. After you log in, as shown here, the lab tab has all cases scanned in the system. The my tab, you can have your private folders as shown here on the lower left. For your personal teaching research, you can tag those interesting cases or slides into those specific folders there. So on the right, you can move this window anywhere you want. You see this case navigation window. But basically, it's a slide tree, for physical slides. Then on the left, you see this toolbar with multiple tools available for you. Then you have this thumbnail image. Look at the entire image. You can do annotation very easily using those tools. You can do the measurement as well. Just drag a line along the area. You can also put a grade on the digital image when you count mitosis or other, like a stand nuclei. I'll give you exact the area, how much is the area. You can do all this all in one single view slice. For example, this is breast resection specimen. You can do the measurement. You can measure the distance from multiple margins as shown here. You can make an annotation and circle those mitosis as well. You can take a snapshot to to save them for your publication, for your PowerPoint. It's very easy to do. Just a single click shown here. And the image quality is very good. I use many of those images for my publication. You can download the entire WSI as a TIFF file or other format for your presentation if you want to use the digital image for your teaching courses or any other purpose. Additionally, you can communicate with your colleague. You see all these, all my colleagues logging here. If I want to invite any of those for, second opening, I can just go ahead and invite them to join this, viewing of this specific case. You can put multiple slides into one single view to help you, navigate the IHC staining or kind of, kneel together multiple slides, or block for measurement. Some of you may wonder whether these WSI's quality are good enough for primary diagnosis. Actually, there is a study published by UK institution, Nottingham institution. They specifically look at the breast pathology using digital image. They did find some missing tissue after scanning, especially those faintly stained with most of fatty tissue, but none of the WSI with the missing tissue, resulting in a change in the final diagnosis, as shown in this table, as you can see here. None of those change the final diagnosis. Most of this is just fatty tissue not scanned. If you compare F to E, you do see those fatty tissues not scanned on the left window shown here. Let me go ahead and show you a case, dummy case in our IMS, how to look at this in this recorded video. These are dummy cases. So breast biopsy after getting into IMS, you can automatically see the digital image. Let me just move this fast. You can zoom in, zoom out very smoothly. The image quality here doesn't look good because I recorded this in the Zoom, which significantly decreased the image quality. But when you look at IMS, the image in IMS, the image quality definitely excellent. As you can see, it's very smooth when you move around, no lagging or delay at all. You can make your annotation and come back there for any additional immunostaining. Let me just move this forward. See. You can look at the different slides very quickly. One aspect I like this very much for those breast slides, you only have a fatty tissue. Most of the time you don't need really go down to high magnification. You can quickly look at those. Then after you look at the ATE, you want to order some immunostain, you can go back to your LIS, order the immunostain. Next day, the immunostain comes out. You can just click the immunostain slides for viewing. Here, you have your immunostain slides. You look around, the slide is not good. There are some bubbles over there. And this kind of a disrupted tissue over there. But I just want to show you this forward. You can put two slides together and align them using this button in the middle. Most of the time, the IMS will automatically align them together. Then you can move these slides together as well. This is a sticky file. Looks like some non-staining, some area. Could be atypical lobular hyperplasia or atypical ductal hyperplasia. Then you can go to your ECAT staining, figure this out, whether it's a ductal or lobular. This one looks like a ductal. You still retain your membrane staining, but this area we just look at, it's probably lobular. You lost the ECAT staining. All right, let's move to the next slide. Besides the primary diagnosis, another benefit you can do, is a remote sign out. You can sign out cases at home or other places than your lab location. CMS issued this waiver for remote sign-out cases during pandemic in 2022 and in 2023, even after pandemic, CMS extended this waiver. So you can still do the remote sign-out at home or other places than your lab place. You can set up your home office pretty easily, connect to the LIS and IMS like VPN, then have a very nice large monitor, but before you do the remote primary sign-out, you have to, for our pathologists, we have to complete the OSU IMS orientation and training, establish a secure OSU VPN connection, and test validate the home monitor using this point of use quality assurance remote tool, and read a total 14 test images, including this number of slides. Here is the point of use image tool. Basically, you just look at these images on your home monitor, make sure you can read through, read those letters behind these colors, then you are good to go. When you do the remote sign-out, we require the pathologist to specify whether this is a remote sign-out or non-remote sign-out at the lab location. We do have options in our iOS system. If you click the remote sign-out, there will be a disclaimer showing this professional interpretation performed remotely at a second location, usually your home address on file. Then on the final report, you will see these different disclaimers as shown here for remote sign-out. Besides the primary diagnosis, you can do consultations using digital image, whether it's intra-practice or extra-practice. The FDA's position on WSI does not apply to consultation diagnosis. We routinely do this secondary opinion using email with the link to ask a second opinion from multiple, colleagues, as shown here. You can simply, put this email, this link to the image for this, or you can invite your colleague if they are in the system, log into the system, do this in real time. We also have a OSU Path Presenter consultation platform to do consultation from outside institution. They can upload their slide digital image into this consultation portal. The AI is in some of AI platforms have been integrated into this platform, such as this ER quantification platform. Besides the secondary opinion consultation, you can also do remote real-time consultation for frozen or rapid on-site evaluation for cytology. We are using hybrid system such as the Sakura Vision Tech, April LE1, Microscan, and Grandium. We were using Microscan, but currently transitioning to Grandium. You can remotely control those robotic microscope, look at the slides, move the slides around. Here is an example from the Grandium. For a smear, you can do this remote consultation for rapid on-site evaluation. You can do this in real time. Just select that window, do this real-time view, or you can just scan it. It won't take much time. We are using digital pathology for our QA. As you can see here in this QA form, we have the slides link, digital image slides link, and also the reports. You can just click those without any paper, then mark your opinion there. We are doing tumor board or other multi-discipline conference using digital image, using IMS shown here for multiple tumor boards. For education as well, signing out with the residents. This is during pandemic. We were signing out case with the residents using Team and also logging into the IMS without any disruption. We are doing education for residents, teaching as well. We upload all our teaching slides into IMS for our residents. They can view them anytime after logging, and we are doing slides exam in the IMS using digital images as well, as shown here. For research, we routinely do, research using digital images, just by logging into the IMS, look at the slides review, select block, and take slides for TMAs, take images and clinical trial and other research as well. For example, I can have, those slides into my specific folder in the IMS and look at them later. So the digital workflow can increase the flexibility for pathologists, especially during the pandemic. You can work from home or other places other than your office. Includes flexibility in staffing, reduce in-person interaction during pandemic, but probably not a good thing to do right now. And improve office ergonomics. You don't need to look at the slides through a microscope, and improve efficiency by, have all WSIs instantly available for everyone, especially for the lab. For the pathology department with a centralized lab, you don't need to transport your glass slides to different places anymore. Just scan them centrally. And these slides are automatically assigned to the case pathologist, and also the residents, if you have a residency program, can look at those slides anytime they want. And our residents like this a lot, because they can go home after a day of grossing without stay here, take turns to look at the glass slides. And no more paperwork, no more manual searching for case slides, the rapid retrieval review of a prior case material, especially when you have a resection specimen, you want to look at the prior biopsy slides. It's just a single click from IMS or LIS. Flagging cases for conference mentioned for tumor board, taking high quality image to improve precision and others. But there are some challenges, such as you have to wait the slides to be scanned, extra staffing for scanning, some challenges for slides reviewing, including some microorganisms such as H. pylori, AFB, and some fungi as well. Special stents such as Congo red, you cannot look at those slides digitally. You still need to refer to the glass slides. Some other subspecialties like pathology, clinical pathology is still not at this time, you cannot do that completely using digital images. So some of our experience were summarized in this publication a couple years ago on arXiv. Now let's move to the foresight imaging analysis AI. I personally separated them into 4 categories: detection, classification, quantification, and prediction. I summarized some of those commercially available AI tools into this table. Some of them have received FDA approval, highlighted in green color, such as Atera, prostate test, Hologic, Genius system for cervical cytology screening, and PAGE, prostate suite, and lymph node metastasis suite. Currently, we are doing validation or pilot study for some of those algorithms and integrating them into our routine practice. I would like, next I'm going to give some examples for those AI tools. The first is the detection tools. We published this article last year using AI to help pathologists to detect lymph node metastasis in a digital workflow. So the process, basically, you have the case metadata and open this in Visualform platform, which will directly stream the WSI into this platform without any downloading and uploading. Then you can select, those AI apps in the menu to do the analysis. then give you the result shown here. Just give you some example. This is a lymph node with a micromass after neoadjuvant chemotherapy. The AI highlights those small metastases as shown here. Here is another example, also after neoadjuvant chemotherapy, lymph node from a patient with a breast cancer. It's a small focus shown here, highlighted by this AI algorithm with only 5 tumor cells there. Some examples from patients with invasive lobular carcinoma, which are usually very challenging to look at, for very large metastasis to small metastasis shown here. Based on our study, this algorithm has a sensitivity of 100%. Basically, none of those real positive metastasis was missed, but the specificity is low, on less than half, less than 50%. Some of those are caused by the following reasons, including histiocyte, crushed material, shown here, germinal center, and others. The frequency of those false positive causes are listed here, and the most common one is a histiocyte. I think let's take a look at time. I'm going to skip this video, go to the next one. This one summarizes the current available AI solutions for screening for cervical cytology. As mentioned, one of them has received FDA approval, which is a hologic genius system, as shown here, with both hardware and AI integrated into this hardware. Basically, scan the entire thin prep slice and give you a gallery shown here. You can click on the images in the gallery and interpret them. You don't have to look at the entire WSI anymore. Other AI systems include cytoprocessor, KF-Bio cervical cytology, Optoscan, LandingMed system, and TechSide. We summarize this available resource in the second part of our digital cytology white paper published early this year, and also kind of give some sort of guidelines for implementing AI algorithms for cytology practice. We conclude that it is premature to recommend a specific number of cases needed for validating AI algorithms, but we did have some recommendations, such as if the algorithm has received FDA approval, a sample set of at least 20 cases per classification category is needed. Then move down to the second category of AI tool classification, which include some examples are page prostate algorithm or an IBEX scaling system, including breast, prostate, gastric. I'm going to give you some example from the IBEX scaling system. We are integrating this platform in our practice. The Gilling breast algorithm, the results was published couple years ago with AUC, I think 0.99 for invasive breast carcinoma, 0.98 for in situ carcinoma. That's really high, the AUC scores. So some examples shown here. This is an invasive ductal carcinoma highlighted by the AI algorithm. The red means high likelihood. After that, you see those invasive carcinoma. The blue shows the DCIS, ductal carcinoma, highlighted by this AI algorithm. Our study shows this algorithm has a very good accuracy and sensitivity. Based on our study, only one very small microinvasive carcinoma was missed by the AI algorithm, but actually highlighted using this green color. which means low probability, but it still highlight the area. This is the missed case if you're using those scoring system. But you do see, this small micro invasive carcinoma highlighted by this system. It can also identify lobular neoplasm, as shown here, highlighted by the AI algorithm, atypical lobular hyperplasia. Our study shows, very good result for identifying lobular neoplasm, as shown here. Other features or lesions can be identified by this algorithm, include microcalcification identification. If you do breast pathology, sometimes you do receive biopsy specimens for calcification. You have to find the calcification. Sometimes it's time consuming and challenging to find those small calcification. This AI algorithm can help you to identify those small calcifications as shown here. See those small calcification. Our study showed almost all cases with calcification were identified, except one case with calcium oxalate. As you know, if you do breast pathology, the calcium oxalate has different color than the most common one, calcium phosphate, which is a purple blue shown here. This one is translucent. It's shown here. It's hard to look at here. Let me skip that. The next category is quantification for biomarker quantification, such as ERPR HER2 or mitosis quantification. Some examples include HER2 IHC. Similarly to the lymph node metastasis detection, we can download the case metadata, open it in Visiopharm, which also has some biomarker quantification algorithms. Select the HER2 AI app, then run the analysis. Shown here on the left, the green color is for the tissue sample, the right color for the controls. This algorithm can automatically exclude the positive control from the analysis, only analyze the tissue sample as shown here, give you the results and the final score as shown here. Our result shows concordance was 87%. All these discordant cases were only one step discordant, meaning either from negative to equivocal or equivocal to positive, or vice versa, but nothing, from negative to positive. Some pitfalls include air bubbles, in situ tumor, or focus can cause either false positive result or negative, false negative results. Let me skip this. You can do the quantification using AI for other biomarkers such as the ER, similar process. Our result shows very good concordance as well. Similarly, you also have pitfalls for ER quantification. Some of those problems include, DCIS for invasive carcinoma. Similarly, you can, use this algorithm to exclude controls, only analyze the tissue sample. In the Visiopharm platform, actually, you can optimize those algorithms by additional training using this built-in deep learning process. Just add more training samples and annotate them. You can do the additional training to optimize it. Similarly, for quantification AIs, you can quantify the cancer grade or quantify mitosis using the AI. Some publication is shown here as well. Lastly, you can use the AI to predict response to therapy, to genetic for genetic alteration or risk stratification for chemotherapy, radiation therapy as well. Here is one of our publication to develop AI algorithms to predict response to neoadjuvant chemotherapy in breast cancer patient, HER2 positive and triple negative. We extract the image features from HE slides and also IHC slides with CD8, CD163, PD-L1. So, you know, those tumor microenvironment factors. Then train the model, AI model, to predict the response in both HER2 positive and triple negative breast cancer patients with very good AUC scores as shown here. You can, you know, predict the survival as well, and using either grading or other morphological features. You can predict the prognosis in those patients, not only breast cancer patient. You can also, you know, predict the response to chemotherapy, similar to Oncotype DX test. If you do breast pathology, you know, it's pretty much routine to have Oncotype DX test for ER positive, HER2 negative breast cancer patient early stage. And this molecular test is very expensive, more than $4,000 per test. You know, you can use AI basically just based on the HE to simulate this Oncotype DX test. You can also predict some genetic mutations, not only for BRCA as shown here in breast cancer, also MMR, MSI, and other genetic mutations. Kind of, you know, screen the patient for those genetic mutation tests to save cost as well. This table, go back to this table, the commercially available breast pathology AI products. I do highlight two commercially available AI products. One is from Orcon, the other one from StratiPath. Both of them have these AI algorithms to predict recurrent risk for ER positive, HER2 negative early stage breast cancer patient, similarly to the Oncotype DX test. Then you can select those patients either for Oncotype DX test to save cost, or if, you know, the clinical trial, if the clinical trial results are out, you can maybe in the future to replace the Oncotype DX test. So with all this, I would like to highlight that AI is almost here, and it's here to help us to reduce our errors and make us more efficient. With that, here are our publications for this talk related to digital pathology and AI implementation. With that, I will conclude my talk, and thank you so much for your attention.
Excellent talk. Thank you so much. Yeah, any questions to Dr. Li? Dr. Huntsman, please.
So, Dr. Li, thank you for the wonderful presentation. Now, I must admit, I had to step outside the room for a minute or so. So if you address this, accept my apologies. So the system which you described seems to be a sort of intermediary system. At some point, we have to get rid of glass slides. And are there any systems in play where sections can be cut on membranes and slide, and we just get rid of the glass completely? It's heavy, sharp, a disposal issue. So you're probably, I'm sure your team are working on this, but I just wondered what's happening. And if you've addressed it already, accept my apologies.
Oh, so you are talking about the different thickness of the glass slides sometimes.
Just getting rid of glass, the same way, because I mean, I'm old enough. I remember when every hospital had people with shopping carts wheeling around X-rays. So we're putting in digital, like got digital images, but we still haven't got rid of the substrate yet.
So for surgical pathology here at our institution, you know, not all pathologists get rid of the glass slides, but for some of the pathologists, including myself, we do not receive any glass slides unless, not those scanning not optimal. We may go back to the glass slides, but it's very rare. We do have scanning failure rate. I think it's less than 1%.
But the lab is still making the glass slides.
We
right?
might,
Yeah, we still keep the
Yeah.
glass slides.
Yeah,
Yeah,
so-
this is the pathologist
Yeah,
not
yeah.
receive them. Yeah.
would you envision a glassless future where there is no glass slide at all?
Well,
No glass slides made.
no glass
Yeah,
slides
that's
are
very
made.
different. Yeah.
Okay. I think there is a new technique, so-called virtual staining, just using the tissue, basically no staining, no glass slides, but I don't think it's feasible at this moment yet.
Okay,
I
thank
do
you.
see some of those images out there. Yeah. Any other questions?
Dr. Wei,
Okay, I do see this question in the chat. What's your rescan rate for missing tissue on the first scan? As I mentioned, we have a scan failure rate about 1%. So I would see, I would probably the rescanning rate is 1%. Yeah. Not only for missing tissues, sometimes, it's not on focus, especially if you have a very thick tissue on the slides, not focused very well, you probably need to rescan them. Yeah. Second question, as for initial digital path validation, what's your recommendation? We follow the CAP guideline. We validate 60 cases, but also include 20 slides for IHC and 20 slides for special stain for each single scanner. For example, you have a 6 scanner, you have to do that for all of them. Okay, we have question, a big limitation for many of those platforms, lack of oil immersion. Okay, HIMPATH is left behind. This system right now, Metal. Actually, I think just a couple months ago, we were testing a scanner from a 3D Histech. They claim they can do the oil immersion on their scanners. The slides, from those bone marrow slides using the oil immersion can be scanned pretty well. However, it takes the scanning time. The scanning takes a very long time. I think more than 10 minutes per slide, and the file size is huge. So we couldn't find a good one yet for oil immersion, although some of those digital scanning systems have claimed that they can do that. Next question, only retrospective validation. Yes, we use retrospective cases, 60 cases and 20 IHC and 20 special stains. All right, next question, can the slide images obtained from one system be used on another one? Switch image system. Yes and no, depends on the image system. Okay, we talked about whether it's an open or closed system. For example, we are using Philips IMS, which is a closed system, only take the iSyntax format scanned by the Philips scanner. So you cannot use that kind of IMS to look at or view other image images scanned by other scanners. However, there are many open systems out there. They are compatible with many different digital images format. Definitely, you can choose one of those open platforms for multiple image formats. Any other questions? I don't see any other questions. I think. Hey, Dr. Go had to leave. I don't know. Okay. Should we just stop here? And thank you again for your attention. All right. Thank you.
Thank you, Dr. Li.
Thank you. Bye now.
Thank you.
Okay.